So good afternoon, everyone. Most of you know me, but my name is Melanie Cavalier, and I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. The MHCC is pleased to present the MHCC MedChi 2024 Fall Symposium, Exploring CRISP Data, Best Practices for Access and Use, as part of our Learning Network initiative. This initiative marks the 14th learning event over the last 3 years. The sessions aim to enhance the knowledge, skills, and competencies of practices to deliver equitable, comprehensive, patient-centered care. This event is being recorded. The format for today's event is intended to promote an interactive conversation. We'll be starting off with a couple of poll questions, and we'll display thought-provoking questions throughout the presentation. To join the conversation, you may raise your hand or enter your thoughts into the questions or chat. For those of you who are not familiar with MHCC, MHCC is an independent state regulatory agency that supports advanced care delivery and practice transformation. We collaborate with payers and providers to transition to quality-aligned, value-based care and to harness the potential of data in facilitating meaningful change. Next slide, please. So this slide outlines important information about CME credits and disclosures. You'll find the accreditation statement, the designation statement, and the disclosure statement on this page. Our planners and reviewers have no financial relationships to disclose. Next slide, please. So today's learning objectives include the value and clinical benefit of health information exchange, strategies for utilizing data from CRISP, the state-designated HIE, to improve care delivery and chronic care management, and tips for incorporating HIE reports, including radiology and lab reports, into your practice workflow. So I'm going to start off by asking a couple of poll questions. So pretty simple one. I'd just like for everyone, if you don't mind, to put in what's your practice specialty and how many of you are currently using CRISP reports. So I'll give everybody just a couple minutes to answer that. So it looks like about 72% of the practices are currently using CRISP, and so about 25 are not. And as far as the details of the specialties, we can go into that a little bit later. Okay, so today, can we go to the next slide, please, the agenda? So today we're going to start off with opening remarks from Jean Ransom of MedChi. I'll then do a review of the current Maryland landscape and select MHCC practice transformation activities. We'll then hear from 4 speakers on our main topic today. The first will be our subject matter expert, Dr. Sheena Patel from CRISP. And then we'll hear 3 practice perspectives. Dr. Lisa Hugh, the founder and CEO of Southern Maryland Dietitian, Dr. Sarah Merritt, president of Lifestream Health Center, and Dr. Sanjay Saxena of Hagerstown Family Medicine. So at this time, I'll turn it over to Jean to proceed with the opening remarks. And the next slide, please, Justine.
So I'm really excited to be giving opening remarks for this particular event. First of all, MedChi, the Maryland State Medical Society, the 7th oldest medical society in the United States, a private nonprofit here in Maryland, is really pleased to be partnering with the Maryland Healthcare Commission on these educational series and on so many things. And we also really appreciate our role with CRISP. If anyone after this meeting wants help signing up with CRISP, Raquella or Sean or someone on our team would be more than happy to follow up with you, or you can talk to Colleen. But we really appreciate having CRISP in Maryland. Maryland has one of the best health information exchanges in the country. We should be very, very proud of this. And it is an incredible tool that is essentially free for physicians that can allow them to actually maximize profits, but also do a better job with regards to population health. There are 4 amazing speakers today on this panel. Dr. Patel does a great job in her role with CRISP. Dr. Saxena is a very successful physician in the Maryland Primary Care Program. Dr. Merritt and Dr. Hughes both went through the transformation grant And Dr. Merritt is actually in the EQUIP program doing some of the ortho pain bundles as well. So all of them have unique and different experiences and use cases with CRISP. And Dr. Merritt also actually has a role with the prescription drug monitoring program, which is another thing that CRISP runs that we won't be talking about today. But you could not have a better group of people to talk about the value and the use for this. I did want to make a quick pitch for the transformation grant. We still have slots open. The MedChi Practice Transformation CTO was given the competitive award to manage that grant process. If you're a newer practice and you aren't using CRISP and you want to learn more about value-based care, we have about 20 slots left for practices to receive training and support to learn about value-based care. We would love to have you involved in it. And having said that, I will stop talking and let the people who know a lot more, they've probably forgotten more than I know about using CRISP for population health and improving practices. So I'll let them give you the subject matter, but you're in for a real treat today. Great job, Melanie and Lisa and Colleen, for setting this one up. It's really exciting. Thanks for having me.
Thank you, Jean, for those opening remarks. We appreciate all that you do for the to further value-based care here in Maryland. The EQUIP has shown to be a great program, and we look forward to its continued success. Next slide, please, Justine. Okay, so what does the Maryland landscape look like? In just a brief snapshot, we have almost 6.2 million people, and 16.9% of those are 65 and over. Next slide. So I'm now just going to do a really brief overview of select MHCC practice transformation initiatives. These are designed to support the Maryland model goals by readying practices to participate in value-based care models. Continuous quality improvement, which is our main, the CRISP reports are a key part of that transformation. Next slide, please. So advancing practice transformation has been an MHCC strategic priority for more than a decade. The first practice transformation program was the Maryland Multi-Payer PCMH program, which ran from 2011 through 2016. The MHCC then partnered with MedChi, the University of Maryland School of Medicine, and the New Jersey Innovation Institute to complete activities in Maryland as part of the Transforming Clinical Practice Initiative from 2015 to 2019. This was a federal initiative that included over 124,000 clinicians. The MHCC has also contributed to planning and policy development for the Maryland Primary Care Program since its inception in 2017. Next slide, please. So in June of 2021, as Jean mentioned, MedChi was competitively awarded a grant to complete practice transformation. A crucial role of MedChi is providing the practice coaching on specific transformation topics, approaches, and tools to help sequence and manage change essential to succeed in the VBC model. The program milestones include readiness assessments, workflow redesigns, and trainings. Approximately 72 practices have completed program milestones to date. As Jean mentioned, we are still accepting applications, so please reach out to MedChi or me if you're interested. The next slide, please. So the MHCC convenes peer learning network events like this one in collaboration with local and national healthcare leaders on topics such as health equity, advanced care delivery, and practice transformation. More information on learning networks is available on our website at the link listed on this slide. Next slide, please. So two recent events that we hosted included a mental health collaborative care summit and enhancing patient experience through patient and family engagement. Next slide, please. So at this time, I'm going to turn the presentation over to our subject matter expert, Dr. Sheena Patel.
Thank you, Melanie, and thank you all for having me here today. We can move to the next slide. So just a couple of questions that I thought might be good kind of food for thought as we go through this presentation to consider, and hopefully I can cover these as I'm talking. But Jean actually mentioned that the cost to participate in CRISP is $0 for our outpatient providers. And so you really have a whole host of information that's available to you and hopefully is really easy to access and is helpful in your day-to-day workflows. How does CRISP secure and protect patient data? This is always something that's at the forefront of our minds. What are opt-out procedures and options for patients? And then, of course, at the end of all of this, if you're interested or are already a participant but want to learn more, how can we make that happen for you? So hopefully you'll get a sense of those things as we talk. Next slide, please. So my role today really is to give you a sense of the what is CRISP part of the conversation, and our speakers later in the presentation will talk more about how they actually use CRISP in their day-to-day workflows. And so hopefully you'll get a sense once you see everything, you'll be able to understand the different options and ways that these things can really be beneficial in your day-to-day practice. Next slide, please. So a little bit about CRISP is that, we are the state designated health information exchange. We serve the state of Maryland, but we are affiliated with other HIEs in several other both neighboring and non-neighboring states. And we'll talk about what those relationships are like in a minute. And we're really here to advance healthcare and wellness and patient care by kind of marrying up health information technology with true cooperation and collaboration with stakeholders across the industry. So we are not here to sell you things. We are not here to compete with solutions that are already working for our providers. We really want to create synergies within the system so that data flows to the right people at the right time most efficiently. Next slide, please. And so I mentioned in the last slide that we are partnered with several other states and their health information exchanges. You can see here that we've got about 8 that we are currently kind of formally in relationships with through our kind of umbrella organization, which is called CRISP Shared Services, which provides a core common set of technology tools and solutions, but is structured in a way that's really dynamic and scalable and flexible so that it can be really leveraged by multiple states and multiple priority use cases. Each individual state or health information exchange shown here has local governance. They work with their local stakeholders to move forward what's most important to them. And we are all able to kind of take advantage of the common technology. Next slide, please. And so I won't spend too much time here, but just to give you a sense of the history of CRISP and CRISP Shared Services, we've been around since 2006, where kind of initial conversations have happened. But I like to just illustrate, show this slide to illustrate the evolution of CRISP. We've done a lot of work over the years, and as we've evolved, we've, become much stronger in the state of Maryland itself. But as I mentioned in the previous slide, we've also been able to share our lessons learned and our technology with other folks in other states who hopefully can take the same advantage that's available in Maryland. Next slide, please. And so as we think about our CRISP services, I tend to think about them in 5 buckets. The first is our point of care and point of care tools. This is generally what you would kind of traditionally think of as you think of a health information exchange and what you would see. This is where you're going to find your PDMP, your clinical records, care team information, things like that are really very, very clinically relevant in the day-to-day workflow. The second bucket of services that we provide are event notifications, and this is through our Send tools. You may have previously heard of it referred to as ENS. It's now called Send, but this is where you're really going to get your real-time event notifications for patients who are kind of in and out of different settings, both in the hospitals and elsewhere. And this can really help to coordinate care for those patients. We have population health reports through our CRISP reporting services tools. And this is where we're able to marry up administrative claims, clinical data to really give you a sense of your population's health. This is where MDPCP spends a lot of their time. And we are increasingly creating reports that are beneficial to all providers, whether or not you are participating in any specific program. Kind of in support of some of these state programs comes the program administration side of things. And so we have a whole host of teams who support the state-run programs that are essentially working with the HSCRC and supporting the total cost of care model in Maryland. And then lastly is probably the newest kind of category of services, but we do serve as the public health data utility for the state of Maryland. And so we've really honed a strong relationship with Maryland Department of Health, our local health departments, and other stakeholders to support public health initiatives, which are bi-directional. And so we are supporting public health officials, but we are also getting data from public health that is disseminated to our clinical providers, and talk about some of those. And on the right-hand side, I like to just give a quick snapshot just so that you get a sense of the volume of data that's flowing through the system. Just focusing in on Maryland, you can see that there are millions and millions of pieces of data being shared across the continuum between users and between providers. And so it just goes to show that, we do have a lot of information available. And hopefully, as I go through some screenshots and show you some of the services, it'll help you, hone in on what makes the most sense for your practices. Next slide, please. And so I like to show this diagram just to give a very simplified sense of kind of the inputs and the exports of the types of data that we see within CRISP. And so on the left-hand side, you can kind of see the types of information that come into the CRISP infrastructure, which includes health department information like immunizations, vital stats, also claims data, and of course, that core kind of clinical data that's coming from hospitals and outpatient providers. All of that data comes into our infrastructure, it gets converted, it gets normalized, it gets matched up with the actual patient and their identity. There's a consent utility that manages opt-ins and opt-outs in 42 CFR, Part 2 consent. And once we get through all of that, we can actually deliver clinical data to our users in a number of different ways, whether that's a web-based portal, APIs, flat files right into some, a data warehouse, for example. Really, the sky's the limit. And so we try to really meet people where they're at in terms of the data they need to see and provide it in the most efficient way. Next slide, please. And so this is just a quick snapshot. I mentioned the web-based portal for viewing most of our clinical data. That is what the vast majority of providers use to access CRISP. But we do also have EHR integrations for specific EMRs. For example, the Epics, the Cerners, Athena, ECW, and a whole host of others. Have the ability to actually embed CRISP within their EMR so that you don't have to log in. It's just a button within your patient's chart that you can click and access all of the same things that you'd see on the web-based side. Next slide, please. And so we'll get into the kind of 5 categories of services, the first of which being that point of care information. And I'll show you what those look like and the types of information available. Next slide. So we all know the prescription drug monitoring program, the PDMP, is generally most providers' kind of first step into accessing CRISP or understanding, what CRISP is as an entity. I won't go into the details of what PDMP is. I'm sure most of you are already aware, but CRISP has been tasked by the state to administer the program, which both means kind of managing the data that's coming in from pharmacies, but also the user experience in terms of allowing providers to access that information. Next slide. And so many of you are familiar with this view of PDMP, where you can see the CDS medications that have been dispensed to patients from pharmacies. And this is something that most providers are required to check and do check on a regular basis. Next slide, please. In addition to the PDMP information, we do also have prescriber insights available to PDMP providers, which is where you can see things like your kind of personal prescribing history, and other prescriber insights that are specific, not necessarily to a patient level, but to a prescriber level. Next slide, please. We also provide, in partnership with the state, certain types of information that are really helpful as you're reviewing CDS medications with the PDMP, having conversations with patients, but we can show you things like overlapping opioid prescriptions, how many different prescribers and pharmacies a patient might be getting opioids from. And these are all things to just drive, a better knowledge set for you as you're talking to your patients about PDMP. Next slide, please. Another really great example of partnership with public health is that we are able to show you things like clinical alerts, which include overdose alerts. And so we are able to get from the state a feed of all of the non-fatal overdoses that have occurred and ended up in a hospital. And we're able to show that alongside PDMP information so that you can get a sense of perhaps patient safety issues or conversations that you might need to have as you're considering prescribing a CDS medication. But it's just a really great kind of example of where the public health partnership is really kind of clearly impacting clinical work on a day-to-day basis. So I always kind of like to talk about that. Next slide, please. And now we'll get into the bulk of our clinical information. And hopefully a lot of you have seen this, but if you haven't, I'll kind of show you where things are. Next slide, please. And so we talked a little bit about PDMP, but increasingly we are interacting with other medications. We've heard over the years that MedRx and just understanding a patient's general medication history is a huge challenge. And a couple of years ago, there was actually legislation passed to show all medications that have been dispensed. And so we are working on getting all dispensed medications. In the meantime, we do get other types of clinical documents that have medications kind of embedded within them. And we've worked really hard to start pulling those medications out discreetly to show you a general list of patients and their medication lists. Next slide, please. And then, of course, you have the core clinical information that we display, and this is where you're going to see in the health records, labs and lab results. You'll see radiology reports and also diagnostic quality images. I should have mentioned at the beginning, but we are connected to all 47 acute care hospitals in Maryland. They are sending us hosts and hosts of data. We are connected to, I think we're up to probably in the 75 to 80% coverage of outpatient radiology centers, over half of the skilled nursing facilities in Maryland. So you are going to see some pretty robust data in here. In addition to radiology, you're going to see clinical notes like discharge summaries, H&Ps, ED, notes, consult notes, things like that. All of these, all the data available here can be printed to PDF. It can be downloaded and then kind of ingested into your own charts. Again, you do have the option to potentially access this data from our In Context app as well. Next slide, please. This is just an example of what a lab looks like. When you click on a lab result, we are able to show you, for example, a CBC, and we do map the findings so that the view here is very similar to what you would see in your LabCorp portal, for example, where abnormal results are flagged. But I just like to show kind of an example of what you actually would see as a provider. Next slide, please. Again, this is a radiology report. These are kind of curated views of the information. You're going to see who signed that note and all of the details around that particular radiology report. You'll see there on the top right, if there happens to be a camera icon corresponding to that report, you can open up the corresponding diagnostic quality image. Next slide, please. And then clinical notes. Like I mentioned, this can include any number of types of notes, including discharge, progress, H&Ps. And these are kind of formatted as a free text document that you can then download to kind of fill in gaps as you interact with your patients. Next slide, please. We also, kind of more recently, but it has been around for a little while, but we also have social needs data. And so, as we know, social needs and social determinants of health are a core component of healthcare. And so we do show in our clinical portal ICD-10 Z codes. You'll see those on the bottom screenshot there. We also partner with hospitals and community-based organizations to pull in or ingest social needs assessments that have been completed. We map those to kind of standard domains, and then we're able to display those for our providers to see, you know, hey, somebody had a social needs assessment done at the hospital last month. The patient's coming in for a follow-up, and I see that they've got, you know, a housing need. This is a conversation that I can work into my appointment with them. So it gives you a better sense of kind of SDOH related needs for the patient. Next slide, please. And then, of course, care coordination. We'll talk a little bit about the event notifications, but, you know, I think we all recognize the importance of understanding the full picture of a patient and understanding who all across the community is taking care of that patient or has an active treatment relationship with them. And so as you engage with CRISP and become a participant, you
only have 2 quarters, but if there
You're
oh,
muted now.
can you hear me now? Okay.
Sorry,
No worries.
We muted everyone.
No problem. So yeah, I was saying, as you onboard to CRISP, we do work with you to share your list of active patients, and you would be able to see the fact of that relationship here in the care team section of our portal. And it gives you a really interesting view of people who you might not have realized, you know, are actively treating that patient. We've had folks say, oh my gosh, I didn't even realize that, you know, this cardiologist was caring for this patient and I was about to refer them to somebody else. And so it's a nice way to kind of wrap around the patient with their current care team. We also display advanced directives. As we all know, advanced care planning is a priority for all of us as providers, but also across the state generally. We partner with AD Vault, which is the state certified kind of advanced care planning technology vendor. And so any advanced care planning documents that have been submitted to AD Vault are displayed here for view so that you can access them. Next slide, please. And so moving into a couple of our supplemental tools that kind of, they're not quite clinical, but not quite anything else. Next slide, we can talk about. We do have a consent form that right now is specifically to disclose substance use information under 42 CFR Part 2. And so if you do have a patient who perhaps is suffering from an SUD, we do have some level of SUD data coming into CRISP. It's not a whole lot. This is, you know, a care setting that, you know, is understandably very protective of their patient data. And so we are working hard to protect it the best way we can. But as the industry kind of moves forward and evolves and we do get more SUD data, you know, this is a great way to potentially access some of that by submitting a consent for that patient. Next slide, please. We also have a full closed loop referral workflow. We partner with Find Help and Maryland 211 and some kind of direct relationships with CBOs. But essentially providers are able to send referrals to community-based organizations. Those community-based organizations can manage their incoming referrals through essentially a work list. And then as they complete or accept or deny those referrals, the fact of that or the status of that is available to the sending provider so that they really get an understanding of, you know, the closed loop and what happened to the patient once they were referred. Next slide, please. And so care coordination, I mentioned the event delivery system. You can go to the next slide. This is our SEND system, CSS Event Delivery Service, previously known as ENS. We just brought a lot of the technology in-house, and so it is our branded term is SEND. These are real-time alerts. This is essentially very close to real time. I mean, within minutes of us getting the fact of an event from a hospital or a skilled nursing facility to it populating for a provider to see. And so we do, you as providers have the option to go ahead and see what I liken to a Twitter feed. You kind of see these notifications on an ongoing basis. A lot of folks have specific workflows around reviewing these every day, understanding who's been potentially, for example, recently discharged from an inpatient setting, and then scheduling them for a follow-up visit that you can bill for. This can be a really robust tool to really wrap around patients and start to coordinate their care in ways that maybe you didn't even know that they needed that coordination for. And so this is a really great tool for that. Next slide, please. And so in addition to kind of the core send functionality, where you kind of see that list of your patients, you're getting a sense of where they are, admitted, discharged, or transferred from a hospital setting. We also are increasingly able to provide much more flexibility in this space. And so, for example, let's say you're a cardiologist and you want to leverage the ENS or the send system, but you don't really want to know about the patient when they sprain their ankle. You really just want to know about these 4 ICD-10 codes that are super relevant to my practice and my specific specialty. We are now able to really configure those alerts for your patient population so that you're really just seeing what you need to see, and you can, get really actionable, kind of useful information. And so that's something that's relatively new. It's up and coming, but I think this is going to be a huge opportunity, especially for our specialists. Next slide, please. And so moving on to CRS, or CRISP reporting services. Next slide. I'm sure many of you who are in the Maryland Primary Care Program know that there are lots and lots of reports available for that program specifically. But outside of that, there are increasing numbers of reports that are available for any CRISP participant. And these are based on case mix data, Medicare and Medicaid claims data, and increasingly we're even pulling in some clinical data to kind of enrich our reports. And so you'll see things like total hospitalizations across your patient population, which hospitals are kind of the most utilized by your patient populations. And we also have reports such as pre-post, which are a fantastic way to be able to see hospital utilization prior to and after a particular intervention. And it's just an interesting way to see whether that intervention impacted hospitalizations at all. Lots and lots of reports here, and we have a dedicated team who can really walk you through your options and really in-depth trainings on how these can be useful for you. And so if that's something you're interested in, we'd love to engage you there. Next slide, please. And then the last category of CRISP services I mentioned is the public health data utility. Next slide. And so as of 2022, CRISP is formally designated as not just a state designated HIE, but as the state designated HIE, we also are mandated to serve as a state designated health data utility, which really is serving a very similar kind of data aggregation technology perspective, but specifically for public health. Next slide. And so as we think about like I mentioned, what an HDU is, we enrich data. And this can be, simple things like during COVID, we were able to take the robust information that we have about patients and patient identities and fill in things like most recent phone number or home address or race and ethnicity to send back to the Maryland Department of Health as they were trying to complete contact tracing, for COVID, for example. And so we're really able to work collaboratively with the state to do that type of work. We also distribute information both to the public health agency, but also back to providers. And so we have things like public health reports that can show hotspotting for COVID cases. But like I mentioned earlier, there are overdose alerts and infection control alerts that are coming from public health that we then disseminate to our provider populations. And then lastly, we enable interventions. And so we're able to flag certain patients based on certain criteria at the point of care. A great example is, if a patient has been flagged as being pre-diabetic, can we notify our providers in some way so that they can either get them into a prevention program or, get them onto the right regimen so that they don't progress into diabetes. We try to get that information into the hands of the right people. Next slide, please. So actually, I think that might be it for my part of the presentation in terms of what is CRISP. And I'll hand it back to you, Melanie.
Thank you, Dr. Patel. We do have some comments and questions in the chat that I'd like to go over.
Sure.
So thank you so much for providing all of us with that information. So the first one was a comment from Alma, who said, we centralized access to CRISP reports. 3 of our team use CRISP reports on behalf of 32 primary care practices participating in CRISP. Would you like to expand on that at all, Alma, if you're still on?
Oh, sorry. I was just responding to you regarding the survey.
To how you use
regarding the survey, why would be like, 75%, whereas maybe one or two users are representing a high volume number of providers or participant or using CRISP reports.
Well, thank you for letting us know that. Thank you. So we have Mega said, hi, thank you for a great presentation. Do you have data on patients redirected from ED for behavioral health services or ED backlog for mental health?
Yeah, I think admittedly, that's probably one of the gaps where we see a lack of data. Like I mentioned, I think when we get into behavioral health, SUD world, there's a lot to be done in terms of sharing data with the HIE. That being said, like I said, we are connected to all of the acute care hospitals in Maryland. And so if a patient was admitted to the ED or even registered at the ED for that matter, we do have the fact of that event. And then, if they were discharged from the ED, perhaps without being admitted, a provider would get that information as well. We are working with the state on contributing data to things like a behavioral health bed registry, connecting more robustly with Shepherd Pratt, for example. So it's an evolving process. We're slowly getting there, but that's probably one of the gaps that I'd say we've got.
Okay, thank you, Dr. Patel. Yeah, I'm actually from Shepherd Pratt and trying to understand how we can quantify some of the bed need and redirection of patients within the state so we can make sure that we can serve our community appropriately. Thank you.
Absolutely.
So another question was about why advanced radiology is not on CRISP.
Let me double check that because I want to say, I know for sure we've been engaged with advanced radiology to get their images flowing. Let me follow up on that because it might have happened.
Okay, great.
In the last couple months here. Yeah.
Dr. Sign wants to know how you add the care team and get the add the patients so that you can get alerts. So I can connect you to Dr. Patel or to someone from the MedChi team, and they can help you to get slide up, Dr. Sign. Okay, so Deborah Small asked, is CRISP available for our paramedics and EMTs in the state of Maryland? And if not, are there plans to include? And can you provide the information on how to improve them?
So yes, all of the EMS jurisdictions that are kind of state partnered are CRISP participants and do have access to CRISP. I think some, they differ kind of jurisdiction to jurisdiction in terms of how they leverage the services, but they do have access or the capability to have access. And on the flip side, we do get EMS data into CRISP so that providers can see when there was an ambulance encounter, or perhaps they had a encounter with EMS but were not transported to the ED. We do have EMS data available on that front too.
Then we have another person who asked about if this data is available to the public, which I think you kind of covered. It's available to specific providers. And then what's the process to get access? We can connect them to you to try to get access. How long it may take to get access to the data after completing the process? Do you have
Yeah. So the onboarding process is generally simple in terms of, there's a few agreements to take care of. Like I mentioned, there's no fees to providers. And then we do ask for a patient roster so that we can identify who you're actively in a treatment relationship with. And that same roster is how you get access to the alerts. Once all of that is in, which generally just takes a couple of weeks, it's a matter of credentialing your users and training up. So I'd say like 4 to 6 weeks if you're kind of a traditional onboarding, but we can certainly work with you in your practice on that front.
So someone's asking if the meeting's going to be available. We do post it on the MHCC website and post the recording and the slides there, so it will be available to watch later. Someone asked to go back one screen. So I think they want to see screen 46. This is Stephanie Harris. Is
Yes.
that the one you wanted to see? Okay.
Yeah, it was just, that one. The one. Yes. Oh yeah. Okay. Yep. That was it. I think that was it. This is Stephanie. I work for United Healthcare, and we do have CRISP available. I don't use it as much, which is why I was here to see kind of like the whole perspective and how I might be able to use it for my job duties. So that's why I was just trying to just get a full circle look at everything to see how it could benefit what I do. So thank you.
I mean, Dr. Patel's contact information here is, if you guys would like to touch base offline and discuss.
Yeah, that'd be great.
Together.
Yeah. Thank you.
So another question, can patients access their own data via CRISP? For example, labs, radiology progress notes, and if not, are there plans to do so?
Yes. So we do have a patient access workflow. It's generally limited because you also can get your patient data. All of the patient data that we get is from providers. And so they would be able to get that same information from their providers, which has been the traditional kind of way of addressing those needs. But we understand that it's easier from a workflow perspective to have kind of one place to go and get your full patient record. We don't directly provide that, but we are working to partner with folks, for example, like an Apple Health or third-party apps, so that if you did access through those kind of vetted organizations, you could get your CRISP data that way. I will say the biggest challenge here for us in moving that process forward, because we do believe it's important for patients to get their own data, is identity verification. That's something that we've not traditionally engaged in from a patient perspective. And so we are being very, very thoughtful and diligent about how we ever kind of share outside of the confines of HIPAA to our patients. So more to come there.
Another question, will de-identified data ever be made available for research purposes?
Yeah, so research is an approved and permitted purpose for our data. We have a research subcommittee that kind of works with folks that are interested in leveraging CRISP data for those purposes. And so if you're interested, we can connect you with that group.
So there's another comment in here about the Maryland Medicaid data on the 7-day connection to outpatient center. Is Larry up on the phone? Would you like to expand on this a little bit?
Yeah, sure. Thank you so much. I was just wondering if you had seen the Medicaid data on the 7-day connection to outpatient care, following an emergency room visit or hospitalization. I mean, unfortunately, in Maryland, it wasn't strong. And I was just wondering if you can reconcile that fact with our accessibility to an elegant system like CRISP. I mean, why isn't that why isn't that access connection stronger for us, given that we have the CRISP system?
That's a great point. Yeah, I have not seen that report, but I'm going to look for it after this call. But I think that's a really great opportunity here. I mean, forums like this, another, connection, like I mentioned with Maryland Department of Health and Maryland Medicaid, like I think we can put out a stronger message that we have tools available for you to help your patients in these scenarios. And so I think I'm wondering if it's a messaging thing or just like people don't know that this is an option for them. But that's really interesting. And I think I will pass that along to our leadership team for sure.
Thank you, Dr. Patel. Another question, is it possible to have specific reports to interface and auto-populate within the patient's record, specifically H&Ps and SDOH? We're a children's rehab hospital, and this will be very helpful for us.
Yeah, absolutely. We certainly don't need to get into specifics now, but essentially we have a whole host of ways that we can send data directly into your systems, and it can be specific data that you're interested in. And so, an example that we've done in the past is, hey, patients registered in the emergency room. We send CRISP that information, and CRISP automatically triggers some piece of data to be sent back into the native chart. And so we can certainly discuss that.
Okay. So those are all the questions I'm seeing at this time for Dr. Patel. Are there any other questions anyone would like to ask? At this time, I don't see anyone's hands raised. Okay, great. So we will do follow up with people. Let's go ahead and move to our next speaker, who is Dr. Lisa Hugh, who is going to give us a practice perspective on using CRISP in her practice.
All right. Thank you very much. I appreciate being here today and being able to talk to you. I'm Lisa Hugh. I'm a registered dietitian, and I'm the founder of Southern Maryland Dietitian. So a few questions that I thought about as I was preparing this presentation were the questions that I had when I was first introduced to CRISP. And I really didn't have a lot of experience with CRISP in any other setting. So firstly, I wanted to find out which healthcare providers can use CRISP. Can a for-profit private practice access CRISP? I was only sort of familiar with it as a tool used by hospitals and larger organizations. And then as I started digging in, I thought, oh, well, this seems kind of complicated. How can it really help us? So thankfully, the team at CRISP has been extremely helpful in answering all these questions and helping us to use CRISP and kind of, become more efficient as a practice. So I'm glad to talk about those on the next slides. So just a little bit of background that kind of informs the type of questions that I had and how we're using CRISP. So Southern Maryland Dietitian is a private practice. We're made up of registered dietitians and clinical nutrition specialists. All of the providers are licensed in the state of Maryland. I started the practice as a solo in-person private practice, face-to-face in a small office in Charles County. During COVID, I pivoted to telehealth. And at that time, I also participated in the Advancing Practice Transformation Program. So all of those factors really contributed to a rapid growth in the practice. Right now, we have a team of 15 providers. And out of those 15, 5 are being onboarded currently. So next screen, please. So some of the challenges that we face as a practice, especially as regards to accessing information about our patients, is first, we don't have any corporate team. We have a clinical team, a small administrative team, but we don't have a lot of infrastructure in terms of accessing data or coordinating with other organizations. Our EHR is not integrated with any other providers or any other disciplines. Sometimes we have difficulty obtaining referrals and medical records. And then again, because we're sort of a lean practice, it can be challenging to implement new tools and new projects in a way that's really helpful to everybody involved. Next slide. Some of the other challenges that we face that are more patient specific is there's a high demand and a high need for nutrition services, but sometimes there's a lack of awareness, and that lack of awareness can present in different ways. So many of our patients have very good insurance coverage for nutrition counseling, but they're not aware of it. Oftentimes, referring providers are not familiar with the insurance coverage and benefits for nutrition counseling. So that's a barrier to care at times. Also, we know that we can see patients throughout the state through telehealth, but oftentimes patients are searching for a provider by zip code. That kind of happens if they're searching online, dietitian near me, it's defaulting to the zip code. Insurance companies generally also default to searches by zip codes. Also, there's a little bit of a lack of awareness of the services that we offer. So sometimes patients think that we mainly focus on weight loss, but we do a lot more than that. We deal with a lot of medically complex patients, a lot of patients with diabetes, tube feeding, very young babies, bariatric surgery, complicated thyroid cases, PCOS, and other medical conditions as well. Next slide, please. So CRISP really has helped us in a lot of ways to address some of these challenges. The main thing is that we have access to more clinical information. So all of the providers in our practice have access to CRISP and can access CRISP to get a more in-depth view of the patient's medical history. That leads us to giving a more robust nutrition assessment, and it helps us to improve our documentation. When we do that, we're able to have more clinical information, more accurate clinical information. That helps us to also be more accurate with our insurance billing. And then we're able to do better assessments. We're better able to assess more of the needs of the patient, which leads to better outcomes for the patients. And that's better for us as a business because it improves our word of mouth, referrals, and impression in the community. Next slide, please. So some things that have helped us to implement CRISP and we continue to use are basically we take the approach of one step at a time. We know that CRISP is very robust. There's a lot of aspects to CRISP. There's a lot of things that we can do, but we decided to just do one step at a time. And as we get good at one step, then we try to implement something new. One of the other things that I've started doing is using an onboarding checklist for all of our new providers, and creating a CRISP profile at the time of onboarding is one of the steps that we follow. We also sort of have a rule of thumb in the practice that when we're in doubt about anything, we sort of ask ourselves the question, have we checked CRISP? So sometimes there's an issue of, we're not sure if our assessments are really thorough enough. We're not sure if we have the full information in terms of medical history to make certain decisions. Sometimes we don't know what the patient's relationships are with other providers or what other care they're receiving. So we don't want to cause a duplication, or we don't want to provide instructions to the patients that are opposite of what another provider is doing. So anytime we run into doubt, we try to check CRISP to get more information. Another strategy that I sort of say in general, but always, is use your resources. So for example, we have a pretty streamlined EHR that works great for us in a lot of ways, but it's not integrated with CRISP, and we weren't able to get that accomplished. Even our EHR is sort of limited in terms of downloading patient rosters, but thankfully the billing company that we partner with has more capabilities, so they're able to help us to coordinate, download our patient roster and upload that securely to CRISP. We also use Google Calendar reminders. So anything that we think we need to go back and review in CRISP, or we want to remember to upload the patient roster or collect data at certain times, we use Google Calendars, reoccurring calendar reminders to remind us to follow up on certain things. Next slide, please. And as we're progressing, we're definitely thinking about next steps and how we can use CRISP to help our patients more. So we're really looking at the Population Explorer and the custom alerts. Our goal is to be more proactive with our past and our current patients. We think that's going to help with their clinical care. It will also help us as a practice to maintain relationships with patients that might have dropped off in the past. The next thing is referrals. So our goal is to be more visible to referring providers in CRISP. And so we're getting set up to accept referrals as a community-based organization. And really, we think that all of these are win-win-win strategies and solutions. First and foremost, they're the right thing to do for our patients. It also helps our practice in terms of our business model. And then it also is helpful to the medical neighborhood that we exist in. Next slide. Oh, sorry. So basically, that's the conclusion of my presentation for today. And I'm glad to accept any questions currently.
Let's give people a second to see if anybody has any questions. So I don't see anything right now. Thank you for sharing your experience with us. And I'd love to hear from practices like yours who are maybe a little bit different too, so that people can see, it's not just for, like the bread and butter practices, that everybody can use CRISP and everybody can find their own way to make it work for them and to help them grow their practice and to help to have better patient outcomes and better patient experience. So appreciate your perspective.
Thank you. I appreciate that very much, because I know sometimes when, as a dietitian practice, sometimes we try to access different tools or different services, and sometimes they're wonderful services, but they might be really streamlined for a different discipline. And although they could be helpful to us, sometimes it doesn't always translate well. But I have to say, everybody that's helped us so far with CRISP has been extremely informative and helpful, and kind of thinking outside the box, and it's been a really pleasant experience.
Thank you. It's great to hear. So congratulations to Dr. Patel and her team for providing good support to the practices in Maryland.
Thank you.
Thank you, Dr. Hugh.
Thank you very much.
Can you move the slide forward, Justine? So next we have Dr. Sarah Merritt. She was also part, as we mentioned, of the Advancing Practice Transformation Program, and she's currently in EQUIP. So I'm going to let her tell you a little bit more about herself and how she uses CRISP in her practice.
Well, thank you so much. So my name is Sarah Merritt. I am a anesthesiologist and interventional pain medicine doctor. So in my practice, I'm also board certified in addiction medicine. So we have actually a pretty wide scope. 80% of my practice is really acute and chronic pain management. And so in caring for these patients, we've really found that CRISP and the health information exchange are really valuable. Obviously, if I'm board certified in pain management, if I write buprenorphine as an addiction specialist, we have opportunities that we're frequently checking the PDMP, but there's so much more to CRISP than that. So the fact that the PDMP is housed within CRISP really, frankly, kind of draws our practice into engaging with it. And so I've got a few screenshots here shortly that I'll kind of show you some of what it just looks like in our practice. We did kind of put these questions up front that might spur a little thought or question, and maybe we can circle back to really more like answer these at the end. Things we'll think about would be what records does CRISP or the Health Information Exchange integrate with? Does it do this with my EMR? Who do I talk to at CRISP to start using some of this data? And then how can I incorporate this into my practice? Next slide, please. So I really just wanted to share some basic kind of operational things of how we interact with CRISP and the Health Information Exchange. So there's probably, two main areas that we use this data, and one would be just the clinical notes, the imaging notes, and the other would be the PDMP. And so in particular, these clinical and imaging notes are particularly pertinent for, say, a new patient. So in my practice, we might have a new patient who may be coming to us with a problem that they're interested in an injection for. We might have a new patient who's coming looking for better pain control of a significant chronic pain problem. And so very often as a specialist, as we are, a lot of times patients have had imaging and diagnostic studies, and it's really helpful for us to be able to access these things. So this is just a screenshot of kind of some of what we can see with the CRISP Health Information Exchange and the way that we navigate it here with these sidebars here under the HIE and context in blue and white there at the top left of the screenshot. There's a little circle here that when you hover over that folder, you get a pop-up that says clinical data, and then these folders. So laboratory, radiology, and clinical notes. So for my practice in particular, if I'm seeing someone for back pain, they may have even been referred from the surgeon. At this point, we can go to radiology and look for whatever studies, et cetera, have been done. And this is an example of one of my patients who has significant pelvic pain, has had a piriformis injection, and has had these multiple studies to the spine and pelvis area. The other, I think, standpoint just from like practice efficiency is that, you can ask the patient in the intake or with the call when you're setting up their visit about what imaging have you had and where was it done. But very often patients don't know, or they may not have that top of mind, or they might say like, oh, I had it done on Hospital Drive. I'm like, well, what does that mean? And depending how savvy your person taking that call is, they might or might not know that means, maybe advanced radiology at Baltimore, Washington, or, does it mean something else within a different Hospital Drive? So in this case, we actually find that it's really fruitful to just hop into their profile. We can look and see what's easily accessible, and then drill down further if the patient says they've had certain studies that aren't there, then we can proceed with follow-up questions and trying to find those. Again, this is this pop-up window that you're seeing. We're going to look at some more screenshots on the next page or two so I can show you kind of what it looks like. Our electronic medical record is Athena. This is integrated such that I can pull this up pretty easily in a visit to get discharge summaries, procedure notes, ERS notes, etc. So let's go to the next slide and look at some of that. So I'm going to show you how we get to the two ways that we get to the PDMP also. I guess that was how we get to the Health Information Exchange data. And we'll kind of revisit that. But next, maybe to shift gears to look at the PDMP and how we search that. So this is a kind of a home screen in Athena. The patient data has been pulled off, and this is actually a patient who had a surgery and is not someone who's like normally prescribed an opioid medication, but was prescribed some around surgery. So in this case, just sort of demonstrating on the far left, there's this menu. There's a med menu. You can see on the right slide that meds is highlighted, and there's a medication list. And then through this integration with the EMR that doesn't cost the practice any money, the cost is in the EMR, but this integration there is not. We can then hit the button for the prescription drug monitoring report and view this like live in the patient's chart in Athena without going out of it. Next slide. And so this is kind of to show you the next step. So after you've clicked on that PDMP on the top left there, you can see there's a fly out those bars. kind of fly out this. I would show you this on a video, except I'm not that savvy to be able to black out parts of a video. It was easier to do with individual screenshots. So here we are. And so then you get this list of medications that's available, and these numbers down at the bottom of the page. You can go back pretty far, back to 2014 or so, when that PDMP data starts. And so again, there are a couple ways to get at the PDMP and HIE data for us. This is one of them, is right from that med list. The other involves opening another window. And I would just share the second way to like open another window to look at the PDMP and health information exchange data. I kind of resisted it when we first got integrated. I was like, how is this saving me any time? I just wasn't clear about it. But then as I've gotten facile with it and comfortable with where the buttons are and what are the functions and how can I see it, I've really found that even in a patient visit, I can hop into it and look for something as we're chatting, even at the point of care, if it suddenly becomes relevant to dig in a little deeper. All right, and so that's this slide or the screenshot on the right side. There's this purple hamburger menu in the upper right side. As you click that, you get a bunch of options. One of them there that's highlighted is third-party applications. And so then that gives you a spot to open a new tab. It opens a new browser tab at that point for the health information exchange. So next slide. And so this is as a third-party integration or as a third-party software. What's good about it really, and why I've come around to really like this way, is because it's automatically synced with that patient, right? Versus I could open up a whole new window of CRISP. I could log in, I could use that two-factor authentication. I could manually put in this patient and get it through, just the CRISP site itself. But really, I'm bypassing those steps of re-entering the patient. We're basically already synced with the profile. Or if there are a couple of profiles to choose from, sometimes I'll need to select one. So at this point, if I want to look at PDMP data or health information exchange data through the HIE from our EMR, then at that point, I've circled a couple of things here. So this shows that if I wanted to look at this PDMP data, it's circled in the top left here, and then here it's going to be that this patient had some higher dose prescriptions after surgery, and I'm checking that out of what have we written, has the patient gotten some from the surgeon, understand what's going on. There's also an option to query other states, and this is a function that I didn't actually know about myself for a little while, but over here, kind of buried here is this hovering, circled this, query additional states. So in this native application, it's going to start with just giving you Maryland, but you do have this option to query the additional states to get more information. Next slide. Is there what? I guess go back to this slide. I'm sorry, go back one. I was thinking I had another slide to show, but there's a folder over here, and there's a folder that says clinical data, and then there are some folders, and you can pick a folder that shows radiology data, just to show, kind of how you pick that. I guess we did review that earlier for that first patient example. Okay, sorry about that. Next slide. Case examples, I just had jotted down a number of times that we've had, just clinical decisions that are influenced by the data that we've gotten from the health information exchange. And you can imagine that, again, if we're prescribing controlled substances, that we have, some special consideration. And so I can update you on a few of those. But it's really affected clinical care in a number of ways. I think this first one, patient JH, who was hospitalized, has a significant back surgery, but really didn't have the name of the operation or his med list. We were able to get his discharge summary, including those dates of the hospitalization. And then at that point, we were in a position to potentially bill for the TCM or transition of care management visit. And you could do that. You could bill for the TCM or transition of care management visit, whether you're a specialist or primary care. And the SEND, or the encounter notification system, the SEND is going to give you the ability to kind of take those opportunities when you have a better awareness of, patients' discharge status in terms of hospitalizations. We have another patient who is someone who was prescribed a chronic opioid medicine, had a biopsy, said she'd been diagnosed with cancer, but that was like all the information she had. She's asking for additional medication. Is this a reasonable request or not? What's the status of the patient? And again, we were able to really understand a lot better what was going on, that she had a significant biopsy, that she'd been treated in the hospital for a period of time, and was really better able to inform our clinical decisions in the care of this patient, and not feel like we were just complying with a patient request without doing our due diligence and really knowing what was going on with her. We had another patient who, where we had the CRISP alert or the SEND alert that's been mentioned earlier. This was like kind of our first really, this was years ago, our first really clinically relevant SEND alert, where the alert was that the patient had been to the ER. And then the story in the ER records was basically that the patient had passed out in the front yard and endorsed to the emergency department staff that he had used heroin. Well, this wasn't information that we had, or information the patient had divulged at any point. And so really we were able to, shift his care such that we could offer, a transition to buprenorphine, such that we could offer treatment for opioid use disorder, which was just not, where we were informationally prior to all this. Next slide. Again, multiple times we've had patients have significant surgeries that they really can't tell us anything about. And then to understand, what's gone on, what is their status, if any other prescriptions from the hospital were given or not, and what's appropriate. I can think of a couple more. Another patient who has had multiple ER visits and many spine surgeries. Actually, I think he's had 10 or 12 spine surgeries. And, he has these episodes where he has loss of bowel and bladder. And, the question is, clinically, is he having Cauda equina syndrome or something else? And at this point, he's actually been diagnosed with functional neurologic disorder because there's not evidence that he has active compression of any of the nerves. And so it's really informed our care and helped us be better able to offer reassurance for those episodes rather than insisting that he goes to the ER every time he has one. And finally, just in terms of total steroid dose, we make injections with steroids at times. And so being able to coordinate care, be more aware of when patients have had injections with an orthopedic or another practice of some sort, and be more aware of their total steroid dose. Next slide. Okay, thank you.
Thank you so much, Dr. Merritt. Again, appreciate the unique perspective that you bring and how you're using CRISP in your practice so people can hear from Dr. Patel, what's available. But I think it's good for practices to hear other practices and how they're using it in their practice. So we really appreciate your perspective that you're giving us today. So I'm looking for questions. Just give us a second here. See if I don't see anyone's hands raised. I'll give it just another minute here. Okay, I'm not seeing any specific for you, so I'm going to go ahead and move on to Dr. Saxena. So our next speaker is Dr. Sanjay Saxena from Hagerstown Family Medicine, and he is a doctor in the MD-PCP. So we will let you hear a little bit about his unique perspective and how he's using the CRISP reports.
Hi, thank you. You can hear me?
Yes.
Okay. So I was asked to participate in this because we have a small office and we participated with several ACOs and organizations over the last few years and done well. So I thought I'd give a small practice perspective and just my background. I've taught in a residency program. I worked in a community health clinic. I worked in a small town of 3,000 people. I worked for Meritus in one of their outpatient practices. And after being there for 5 years is when my wife, who's a family doc, and a friend of ours who's a family doc, opened up our own small office. It's the three of us. We have 2 MAs. We recently hired a third MA, and then we have about 3 office staff. So we have no office manager. I'm the office manager. You know, I put nails in the wall, clean toilets if I have to, as does everybody else in the office. We don't partner with the CTO. We don't have a care manager. So we kind of do everything ourselves. And we are part of 3 different ACOs. You know, one is the Care First PCMH, another is Alidate, and of course the MDPCP is what probably warrants or takes up most of our time and attention. So the other part of my background is that I have coding experience. And so I learned years ago that yes, I can be a good doctor, but if I'm not a good businessman and I don't know how to code and bill properly, you know, then I'm going to have to see a lot more patients. So, you know, the term work smarter, not harder, really means a lot and has paid off in the last few years. So the reason I have attitude, if the next slide, you'll see, as healthcare providers, you know, we want to spend our time taking care of patients, providing good care. We don't really want to think about, did I give enough flu shots? Did I give enough pneumonia vaccines? Did I do an eye exam or not? We do those things, and most of the time we document, but we also need to pay attention to, somebody's got to run a report. Somebody's got to look at that data and then report back to any areas that may need work or follow-up. And so that's why I say, you know, we all as a healthcare provider need to have an attitude in terms of, yes, these are metrics. Yes, they don't really, you know, do patient care, but they are involved in patient care. And so I learned quite some time ago that I actually like to do these things. Next slide. And I think for me, it just gives me a sense of accomplishment. You know, if you give me a list of annual wellness visits and there's 100 patients I need to contact, if I go down the list, I get to the end, I'm like, wow, you know, I got that done. I got that list done, makes me feel good. Patients get taken care of. And so part of one of the persons I've worked with in the past is Dr. J. Fantastic doctor, really nice human being. But whenever I would start talking about these metrics, guidelines, goals, I mean, their eyes would just glaze over. And so I quickly found out in that person's office, there was a billing person who had an interest in this. So in their office, that's the person we identified. Okay, here's the website. This is where you need to go to download reports and then research the data and figure out who to go to next. So in my office, obviously it's me. I run reports and then I go to each of the providers and say, hey, you know, this person needs this person needs that. These are things that we need to do as an office. And then they in turn look at that information as they see the patients, and then either they submit the data, they add the CPT2 codes, or they will in turn go to their medical assistant or to billing finance or scheduling person to actually implement whatever change they need. If it's a list of annual wellness visits that I give to them, well, then they will, you know, see who needs to come in, when they need to come in, and then they'll give that list to the scheduler to make phone calls and get them arranged and bring them into the office. But yeah, okay, if you go to the next slide. So the next part of, you know, doing this is to identify who all is involved. So like I say, in my office, we have medical assistants and we have billing coding person. We have 2 people that schedule. So each person is involved, and we have an office meeting on a regular basis, every 2 weeks actually, and we do daily huddles as well in case something comes up. But everybody knows their job, everybody helps each other out. And I explained to the office staff that there is data mining going on in the background. Yes, we're entering codes, we're entering office visits, we're doing phone calls, but the software in the background is picking up those things. And at the end of the year, I report to CMS and let them know what we've done and what we haven't done. And And, you know, that's where you get a bonus or you don't get a bonus. But it's very important, I think, to involve the entire staff. But it starts with one, identifying one person to be the main one that everybody reports to, disseminate the information, and then implement it. Next slide. So some of the reports that are available on CRISP, then if you go to the next slide, and again, there's 3 slides here. There's one for ED visits, one for PQI, one for AHI. These reports I run on a regular basis to find out who's been in the ER, who's been in the hospital, who is at high risk for needing intervention. And some of the other ACOs combine all that information to develop a list of, when we have our meetings, of, okay, these people haven't been in for 3 or 4 months. They were just in the emergency room. We need to contact them. We need to have this done. And that way we stay ahead of the game. And I still round at Meredith. I still see my own patients. And because of that, there's been times where with some of these reports, I can see that somebody either was in the ER or currently is just checked into the ER. And when that happens, there's been times I've called the ER and said, listen, I just saw them a few days ago in the office. They had numbness in their arm. I'm working them up for carpal tunnel syndrome. They don't have a stroke. That's not what's going on. Because I know I'll get a phone call with weakness in the arm and somebody's got diabetes and blood pressure. You need to put them in observation or admit and do a stroke workup. But having that contact, knowing they're in the ER, I've been able to avoid many hospital admissions and observation stays, which again, patient feels better. They don't have to be admitted. ER feels better because I'm taking over care. And in the entire health system is benefiting by not having to have that expense of hospital stays. So that's where some of these reports, I think, really do help me out in trying to get ahead of avoidable interactions like that. But yeah, that's kind of my small practice perspective. You know, the main is to, one, identify a individual who can go through the different websites and ACOs and download reports, disseminate to the providers, and then they in turn figure out who needs to be responsible for the actual work that then gets kind of disseminated to everybody. So everybody does need to be involved in the overall patient care. That's all I had.
So thank you, Dr. Saxena. So we do have a question that maybe you can address. Someone was asking about a code to build to search the data because, you know, it takes a lot of manpower and cost to the practice. So how do people, I don't know if there is an existing code, but I'm just saying, like, how do you kind of work this into the financials of a practice to review and pull reports and things like that?
No, unfortunately, that's built into the E&M code. So, you know, if somebody came in for just a simple bronchitis or a sinus infection, you're probably going to bill a 99213. You know, if they've got complicating COPD, diabetes, heart disease, and there's still bronchitis, well, you're going to maybe go on a website to see if they were in the ER. When did they last use their inhaler? Were they hospitalized for something? Did somebody do a CT? So that's data that in your notes you're going to write that you looked up those things. So even though it would have been a 213 because you've documented that search, now it's going to be a 214. So you're actually increasing your reimbursement by changing the level. I've not seen a code where you could say that that they will pay you to go look for data. And again, if it's based on time, then you spent 15 minutes looking for data. So now the 20-minute visit becomes a 35-minute visit, or the 30-minute becomes a 45-minute. And if you're going to write down that you spent all that time searching for the data and you document the time, then you go from a 99214 to a 215. So that pays you an extra $30 for the time that you spent. And there are time-based codes where if you go over 45 minutes or 60 minutes, there's extra time now that CMS is paying for. In the past, up until a few years ago, they were there, but a lot of commercial insurers wouldn't pay and CMS didn't pay. But over the last couple of years, especially for primary care, they are now starting to pay those codes for extra time spent. Beyond like the 99215, if you spent, say, 75 minutes with somebody, the 215 will pay you to the 60-minute, then the extra 15 minutes you use the extra code, and that will pay you more for the time you spent.
And then someone's asking me about the risk stratification. So can we go back to the, I think it's a slide, 2 slides before this? Can you comment on that a little bit? These are the MDPCP reports, right?
Correct.
Yeah. So the risk stratification is done by a third party, and you just download this report. That's available to you because you're in the program.
Right. Yeah,
Right.
I mean, CMS is doing all kinds of stuff in the background. This is where HCC coding comes in. Surprisingly, you would think, hypertension affects every part of your body. It doesn't even have an HCC code. But diabetes, plain diabetes is an 18 or a 19. Diabetes with eye, foot, heart is 18. And it's the most critical care code is 1, like an HIV or dementia. And so I think 200 or 220 is the highest code, which is gives you the least credit. So when you submit diagnoses codes like this, CMS looks at that. When you submit a prescription for Lexapro or for diabetes medicine, CMS sees that. When you order a hemoglobin A1C, they see that. When they've been to the ER, they see that. So in the background, CMS's metrics computer is taking all that into account and adding up the risk. And then it goes up into the red and say, oh, this person has a risk of, say, 15 or 20 based on that. That means that they are extremely high risk for winding up in the ER or something bad happens. And so you need to address and intervene. And, if they're stable and you've done a good job taking care of them, great. But it's just CMS looking at all the stuff in the year that's been done and giving them a risk code. And that goes, if you're in the MDPC program, the higher the risk, the more money that you're being paid to manage that person. So your quarterly payments go up. So, in the past, I'm one of those picky people with documentation. I wanted a very clean record. So I would say, I just want diabetes. I don't care what kind of diabetes it is. But now I'm like, oh no, I'm going to put in diabetes with heart, diabetes with vascular, diabetes with nephropathy, and the CKD, and hypertension with CKD, because now that's giving me more credit because it says that my patient is more complicated than just a plain simple diabetes. And so that makes you look like you're taking more care of more complicated patients, and your reimbursement starts to slowly increase because of that.
Thank you very much for providing your perspectives today, and to all of our speakers. So Dr. Patel or Colleen George, can one of you guys just put the contact information for practices to who they can reach out to if they would like to sign up with CRISP or learn more about using CRISP reports? So I just want to remind everyone the recording and slides are posted on the MHCC website. My contact information is on this slide. And as a reminder, you're going to receive a questionnaire in the next couple of days. I ask you to fill it out. It is required to receive the CMEs or the continuing education units. So I think that's it for today. And I appreciate all the attendees and the speakers. And thank you for a great event, and have a great weekend. Thanks, everyone. Bye.